Hello and thanks for tuning in. We're here to share some expert knowledge on the diagnosis and expectant management of omphalocele. This information was brought to you by the Fetal Diagnosis and Treatment Committee, and specifically the members listed below. We hope it's helpful for you, so let's get started. Omphalocele are a relatively rare condition, occurring between 2.5 to 4 per 10,000 births. This condition is usually diagnosed during the second trimester, usually with a screening ultrasound at about 20 weeks of gestational age. On this ultrasound, you can see the herniation of midline abdominal contents, which may include abdominal viscera, including liver, spleen, and other organs, and you may or may not see the presence of a sac. On the ultrasound, you can also potentially identify where the umbilical cord may insert onto the hernia sac, and also see the presence of other anomalies. In fact, up to 80% of omphalocele can be associated with other anomalies. The ultrasound can also be used to better define the omphalocele with some broad general categories, one of which is the giant omphalocele, which defines an omphalocele that is greater than 5 centimeters of a fascial defect or has more than 50% of the liver herniated. Another broad category of omphalocele are ruptured omphalocele, in which the membrane sac is no longer intact, and these can be small or giant with a loss of domain. In addition to the prenatal ultrasound, there are several other important prenatal adjuncts that can better define the omphalocele and also be important for prenatal conversations about expectant management. Starting with the echocardiogram, which can be used to evaluate cardiac defects. In fact, up to 50% of omphalocele can be associated with cardiac anomalies. Another is the MRI, which can help us better define the omphalocele, including better defining the chest wall capacity and lung volumes, giving us a ratio of observed over expected fetal lung volumes, which can help guide prenatal conversations. And less than 50% of an observed to expected fetal lung volume ratio can be prognostic of an increased odds of mortality. MRIs can also give us a clue of other anomalies by having a constellation of biomarkers, including pathology of Cantrell, bladderextrophy, and trisomy syndromes. Another adjunct of care is the use of serial ultrasound, which can be used to track the progression of the defect as the fetus grows in size, and to define the ultimate herniation of abdominal wall contents. You can also consider using maternal serologies and amniocentesis, which can support the diagnosis of omphalocele and associated genetic anomalies. There's no proven role for fetal treatment at this time, and prenatal care often involves monitoring the pregnancy and birth and coordinating with a team of specialists for immediate postnatal evaluation and surgical care.
In terms of delivery planning, ideally as close to term as possible to prevent the effects of prematurity on the pulmonary function. And vaginal delivery is typically preferred, but the major concern is omphalocele rupture. So with small omphalocele, vaginal delivery is usually possible. With larger omphalocele, you can consider C-section if there's concern for protecting the sac and the liver. But really, it's important that all pregnancies with a diagnosis of omphalocele, especially giant, should deliver at a tertiary center so that they have access to pediatric surgery readily. Mothers in rural areas may need to be closer to a tertiary center in late pregnancy. So up to 80% of fetuses will have associated anomalies, including various genetic defects. Cardiopulmonary anomalies may be the biggest predictor for poor outcomes, but it can be associated with Beckwith-Wiedemann, trisomy 18 and 21, Prader-Willi, and pathology of Cantrell. So really, in terms of the post-delivery screening, chest x-ray and abdominal x-ray are used to evaluate the lungs and the vertebra, whereas an echo is crucial to look for cardiac defects. Abdominal and renal ultrasound is important to look for genitourinary defects, and then a genetic screening, at least a karyotype, is recommended, as well as a genetics consult.
Management of an omphalocele is based on the size of the omphalocele and any associated complications. Small omphaloceles can be repaired primarily and usually within the first few days of life. Giant omphalocele management depends on whether or not it is ruptured. Non-ruptured omphaloceles can be managed with a paint and weight technique. This allows for epithelialization and delayed repair. The painting is done with substances with antimicrobial properties that promote desiccation and escarization and subsequent epithelialization. Multiple paint options are available. Betadine is one classic option, however, has the added challenge of potential thyroid dysfunction from iodine absorption. This will need to be monitored if betadine is used. Silver sulfadiazine, known as silvadine, can also be used but may have the problem of high silver absorption, resulting in allergic reaction or skin discoloration amongst other potential side effects. Bacitracin is another option that is being used more commonly recently and seems to be relatively safe. When it comes to giant omphalocele, most surgeons will avoid surgery in the neonatal period to allow for early enteral feeding and improvement of respiratory status. As for ruptured omphalocele, coverage is imperative. This can be done with mesh placement to bridge the defect, followed by either primary or delayed repair. In ruptured giant omphalocele, a silo may be needed to reduce the abdominal contents slowly. In this situation, abdominal visceral reduction may take several weeks to months to achieve. Ideally, one would use the patient's native tissue to achieve closure of the abdominal wall in a natural anatomic fashion. But in some situations, the defect may need to be bridged with mesh. Mesh options can vary and can include Gore-Tex, Prolene mesh, or biological mesh such as bovine acellular pericardial patch, stratus, or alloderm. There are various other management techniques for omphalocele. These can include using the umbilical cord or non-adhesive dressings to help reduce the sac. In addition, Botox has been described to aid in relaxation of the abdominal wall and facilitate subsequent reduction of sac contents. This is typically done as a one-time injection of Botox and subsequent abdominal wall closure in 30 to 45 days following injection. Other variations of the paint and wait technique include the use of silver-impregnated dressings, such as Meplex, or even honey-based dressings. These follow the same concept of the paint and wait method in that they aid in desiccation and epithelialization of the sac and will typically be coupled with gradual compression of the sac. Another method that has been described is the use of the wound vac device. The wound vac device is used to apply pressure on the omphalocele sac and aid in reduction. The dressing is changed, as is typical for a wound vac, approximately every 3 to 5 days. The wound bed can then be allowed to epithelialize or can even be covered with a skin graft. Finally, the surgical technique of component separation is a well-known method for closure of giant omphalocele, and, with the relaxing incisions, allows for native coverage over the large defect. Alternatively, the use of tissue expanders has been described and utilized as another method of native coverage of the defect.
When it comes time for repair of the omphalocele, you first want to consider the respiratory or ventilator requirements of your patient. Those with high requirements may be better served with a further delay in repair or a staged repair. Once you're in the operating room, you want to check the peak airway pressures during your primary repair. If the pressures are high, you could consider a Botox injection into the rectus abdominis muscle, or you could consider a staged repair. Finally, post-operatively, we like to initiate feeds early with enteral feedings at signs of bowel function with either stool production or a decreased volume or color change in your uplogal output. When looking at outcomes of patients with omphalocele, those with giant omphalocele tend to do worse overall. They have a higher incidence of cardiac and diaphragmatic defects and a higher incidence of respiratory insufficiency and pulmonary hypertension. Patients with omphalocele are potential candidates for ECMO support in cases of pulmonary hypertension, but overall, outcomes are poor when looking at large database series. Additionally, these patients have higher incidence of neurodevelopmental delay and motor delay. Surgical long-term follow-up could be considered for patients with omphalocele to evaluate for adhesive small bowel obstruction or ventral hernias. Finally, consider early initiation of enteral feeds both pre- and post-operatively. Those with small omphalocele may have reduced stature and poor weight gain early in life, but this tends to improve by early childhood. Patients with giant omphalocele, however, tend to have long-term feeding difficulties with a higher risk of requiring a gastrostomy tube or post-pyloric feeding. Based on a survey conducted with members of the American Pediatric Surgical Association, we have created this pictograph to describe a basic algorithm for how you might consider caring for a patient with omphalocele. From the members of the APSA Fetal Diagnosis and Therapy Committee, we hope that this expert talk on omphalocele management will be helpful in your daily practice.